Welcome to the Hurley Healthy Living event, Brain Bleeds and Aging, Recognizing the Signs and Seeking Help. If you have questions for neurosurgeon Dr. Christian Bowers during the live event only, you can text them to 248-935-2562 or submit your question on Facebook or YouTube. Dr. Bowers is board certified and has trained under 2 different globally recognized neurosurgeons. Dr. Bowers is bilingual and is committed to serving diverse patient populations. He has already helped bring several first-time procedures to Hurley, giving patients expertise close to home. Dr. Bowers?
Thanks for having me. Good to be here. We're going to talk about these brain bleeds and how they occur as people age and how you can recognize and treat what we're calling kind of hidden bleeds, because these bleeds can be present and oftentimes are without people knowing about it, and then symptoms can eventually progress and develop. So what we're talking about specifically today is subdural hemorrhages, or subdural hematomas. And what happens is when you're younger, up into early adulthood, you have your brain, and then you have outside of the brain there's the dura, which covers it, and then there's the skull. As you age, your brains tend to shrink and atrophy, as every other parts of the body do as well. And so the veins that are bridging veins, we call them, that connect the brain and they're up into that dural lining, they get put on stretch. And so you can have shearing with blood leaking out of these spaces, out of these vessels, and creates this area, this potential space gets filled with this subdural blood. And so that's what this little diagram is showing. You have this ruptured bridging cortical vein, and there's between the brain surface, the pia, and the arachnoid matter, and between the skull, the 2 layers of the dura, and the skull above that, you have that potential space that gets filled with blood. And that leads to this inflammatory cascade where they can progressively become bigger, and that can start pushing on the brain. So this is just another diagram showing these veins and how that happens. You have the bridging veins which pass through the subarachnoid space to drain into the major vein there in the middle, the triangular shaped vein, the superior sagittal sinus. And then what happens if there's fluid and blood collecting in that space is we know that the middle meningeal artery, MMA there, it penetrates the dura and has this rich network of blood supply. And so it will release these inflammatory cells into that space as blood gets in there. And that promotes more inflammation. You get more leakage out of these vessels. And it's a cycle that kind of can progress. And if you think about as patients age, their brains are shrinking or atrophying. They're on lots of blood thinners as people get older for different risks of stroke. So you can imagine little minor incidental traumas, little bumps that wouldn't be a big deal before can start bleeding into that space. And if there's on blood thinners, they won't clot easily. It can start this big cascade, and that's what happens. And so there's a lot of variations into the shapes, the sizes, and the timing of these different subdural hematomas. This is an example of 8 different subtypes. I like this diagram from this paper because it shows the different ways. You start with the hypodense one, which is older. You have isodense, hyperdense, maybe more acute. You have this clear on the upper right, this sedimented layer with 2 clear distinct types of kind of a fluid level in there. And then you have a laminar type. We see a lot of these bridging vessels, or the trabecular type, which is important because a small hole for treating those is not going to get, those are all separate pockets, you can think of it as. So you'd have to do a bigger surgery to drain that if it needs treatment, in order to get more of that blood out. And then there's a subacute, which is you can have more acute bleeding into these spaces, and maybe you find it a couple days later. So I think it's important to know, and one of the reasons, the purposes of this talk today is to discuss how there's not a one-size-fits-all, and how as people are aging, we've talked about frailty before, and in this conference, and this silver tsunami of how this population shift is happening. We're going to have older and older patient population, and so we should be aware if someone is an older age and they have risk factors, maybe they're on blood thinners and they're not acting right, they're having one side of their body is weak, we should be thinking of how this can happen. These are CT scans showing the same things that the diagram was going, just showing you how that would appear on a CT scan in the emergency rooms, which is oftentimes how they're discovered. And just to recap, you really want the brain to be like a mirror image, and to be, if you put a mirror there, each side is the same. So you can tell in all these pictures, there's a collection that's pushing the brain over in some degree. And those are all the different types, again, that are from this diagram, causing various amounts of brain shift. And when people have this shift in the brain, it's dangerous. They get a lot of manifestations, clinical manifestations, and different symptoms. So we measure the overall size of the subdural hematoma, and also how much it's shifting the brain if we draw a line down the middle. And so those things all play a big role in how we treat these and manage these for the patients and what symptoms patients have. So what's interesting is in the next 5 years, this is going to be the most common neurosurgical brain disease. So that silver tsunami, we're going further up that peak, and we're going to have this as being the number one treated entity that neurosurgeons manage. And that's for the factors we talked about: the brain atrophy. If people have excessive alcohol use, that'll predispose it. People that have had shunts placed before, all kinds of increasing blood thinner and antiplatelet use, as we talked about. And as we said, you can have bilateral subdural hematomas as well. Bilateral subdural hematomas occur a quarter of the time. And so the symptoms are the kind of symptoms you would expect with maybe transient ischemic attacks or TIAs or strokes. People can have headaches, they can be confused, they can have the stroke symptoms, and then with that would be different sides of the body affected, weak on one side, difficulty with speech, left-right dissociation. And so for mild chronic subdural hematomas, people have tried steroids or statins, but if it's moderate or it's not causing significant headaches or neurological symptoms such as weakness or speech arrest, sometimes we can treat these with a middle meningeal artery embolization, which we'll talk about more. And then, moderate to severe, people have severe headaches, they've got weakness. Obviously, if they're comatose and there's all that shift, this is where we can do surgery, either a craniotomy or little burr holes where we wash them out and place a drain. And I always, when I talk about chronic subdural hematomas, when I had a really busy brain tumor practice, you could see your brain tumors at 2 weeks, and then you come back and see them at 3 months with an MRI, and pretty soon for a lot of those patients, you would be distancing your follow-ups. But it was the chronic subdural hematomas after a burr hole treatment, you'd be seeing them almost every week because their cardiologists and internal medicine doctors want them right back on their blood thinners. But a lot of times you get the majority of the clot out, but not all of it. So you're trying to figure out when to start it. And you would be seeing these patients would require a ton of time. And so I kind of was well-timed in my practice. When I started practicing in 2017, we didn't really use this for the first year. And so I was doing a lot of these subdural hematomas, and you would have this 15-20% recurrence rate where you'd be seeing these patients back time and time again every week, every other week, really, and then trying to figure out. And a lot of times you'd have to go back sometimes. And so this has really been a revolutionary change because I can count on one hand the amount of times I've had to take somebody back since middle meningeal artery embolization came out as a treatment. So we'll do the surgery initially, especially if it's severe, and then we will embolize the artery. And that really, really cuts down on the recurrence rate of these. It's been a really game-changing technology, which we're happy to offer here at Hurley. And so when you do middle meningeal artery embolization, if people have only mild symptoms and a mild collection and you do it, the need for rescue surgery is only 5 to 10%, and less than 5% complications occur with that. So repeat surgery is what really has been changed with middle meningeal artery embolization. Once you do surgery and you do an embolization, the chance of it having to go back to the OR to get further surgery, I think it's smaller than that in my experience. And so this has been a big change for that, and really has revolutionized the field. And so it's another tool in our weapon, in our armamentarium, we can use to manage these. And these are really just going to become more and more common. And it behooves everyone to be aware of them and know how to treat them. This is a middle meningeal artery embolization angiogram picture showing, these are what the runs look like. And then they put Dr. Labarge or his team puts these embolic materials in, and then you won't be able to see that vessel on the next run because it's blocked off, clotted off. And they can get a good penetration and cut off all that little vascular blush that was feeding that area that wanted all those inflammatory cytokines, those messengers that were trying to recruit all these blood vessels, and really prevents these from sticking around. So this whole thing is to really try and prevent recurrence of these non-acute subdural hematomas, and also to sometimes treat them standalone with that if it happens to be smaller but big enough to cause moderate symptoms. We've written papers on this using frailty as a predictor of poor outcomes in patients with chronic subdural hematomas, where we really summarized the literature and showed that worse outcomes were associated in patients that were more frail, that had these conditions of the generally older group of patients these come from. And there was, with those 3 New England Journals of Medicine articles, we just submitted a letter based on these 3 randomized controlled trials that were just published in the New England Journal a couple months ago, discussing the need to incorporate frailty assessments into their discussion of chronic subdural hematomas, because the 3 big trials hadn't really looked at frailty. And we know that that plays a major role in pretty much everything we've looked at in neurosurgery. We've published 100 papers the last 3 years covering that. And essentially every pathology we've looked at, frailty's played a big role. And so we believe that is something that the New England Journal is going to need to look at for subsequent studies down the road, that's going to play a major role in delineating who does well and who doesn't, relatively speaking. So in conclusion, as a population ages, these non-acute subdural hematomas are going to become more and more prevalent. They're going to be the #1 neurosurgical disease that's managed. And symptoms usually, almost always, are not initially present, but they will frequently occur over time. What is also really common is to see patients with acute subdural hematomas, older people. They come in and it's just small, and so we don't need to do surgery for it. We watch them for a day or 2 maybe, and they go home. And I always write, we'll see you back in a week, for the scan. You do like a 7 to 10 day CT scan. But if you have symptoms, make sure you come back to your primary care doctor, or if they're severe, go to the emergency room. And it's common that we see these turn into chronic subdural hematomas as well, and they get more, and subacute, and they get more mass effect. So we have to kind of always be aware of that. If you have older people that are taking blood thinners, that are falling, or that are just on maybe dual antiplatelets or blood thinners and antiplatelet agents, these are all people, if they're frail, maybe there's been a history of alcohol abuse, they're all people that are high risk or prone to developing these collections. So you have to watch for and be vigilant. If someone's not acting right, especially if they have neurological symptoms, speech arrest, they're weak on one side, kind of be cognizant of this and know that these patients can do really well. The middle meningeal artery embolization has been a game changer for this. And we, since I arrived, we've started doing this, and Dr. Labarge, has had great outcomes working with us getting these done. So thanks for letting me share these with everybody today.
If you have questions for Dr. Bowers, he can answer them now during this live broadcast. Text questions to 248-935-2562 or submit your question on Facebook or YouTube. Dr. Bowers, let's start with Leah. She says, how long should you let headaches continue before getting a scan?
Well, that's a good question. Headaches are really, there's a lot to headaches when we take history of headaches. I always tell the story that when I trained in my residency, the longest wait time for any doctor or healthcare provider wasn't a doctor. It was the headache person. They were a nurse practitioner, and they had 2 doctor fellows working underneath them, and it was over a year and a half. So headaches are very, there's a lot of variety to them, and it really matters. So if the answer to that question would be how long has the person had headaches? Let's say it's lifelong. Well, if it's a lifelong symptom, that's probably less urgent. But if it's something that's brand new, or you're not a headache person, all of a sudden you get headaches, that's concerning.
Catherine says, can old brain bleeds cause issues later?
If we're talking about these subdural hematomas and they're older, I think this talk was trying to highlight some of the issues they can cause. They also can go away. Sometimes they're discovered and they're smaller, and we'll watch them and they'll disappear. But once they've resolved, they won't usually come back unless there's another event that causes it.
Leonard says he had a subdural hematoma treated successfully. He's careful now not to fall or hit his head, but should he be getting more follow-up tests?
No, not necessarily. I wouldn't go looking for trouble. It can't make you better than normal. But I'm glad you had a good outcome. But yeah, if you've had one, you probably are more at risk to have another one with a fall. So I would tell them to always be careful to not fall. And falling is dangerous especially when you're older. And so I'm glad he's been doing so well. But I don't think he needs to worry about seeking out care if he's not having symptoms. I wouldn't scan people that aren't having symptoms, because you might find a little collection, and that's okay if it's a little collection that's not gotten bigger. And I don't really believe in chasing small things if they're not symptomatic. That
leads into Cynthia's question: is there a certain age you're at greater risk?
It varies for some people, because if people are more frail, or let's say someone had alcohol abuse for a long period of time, the brain will be significantly more atrophied, and so they would need to be watched earlier than someone who was didn't have those risk factors. So I wouldn't say there's one set age necessarily. You can use 60, but we actually really know that it's kind of an individual patient-related matter. And in particular, we believe brain frailty plays a role, how much brain atrophy there is, and so forth.
Teresa says, can it be stress-related?
We don't have any set link between stress and the brain bleeding, but I don't think stress in general, excessive stress, is good for anybody.
And John wants to know if it shows up on an MRI.
Yeah, it shows up really well. One cool thing about an MRI is between the T1 and the T2 sequences, we can actually time how old the blood is. With that. It's one cool thing MRIs will do with subdural hematomas in general, is based on the different sequences, and we have to memorize them for our boards when we're first learning them. We have little acronyms, but you can tell how many hours and how many days they generally are based on their characteristics on those sequences.
Patricia says she gets quick, severe headaches when she's exercising at maximum exertion. How does she know if that's a problem?
Well, I think it's good that she's exercising. I think that a lot of what we're talking about today generally there's not a lot of people running marathons that have these, you wouldn't be having chronic symptomatic chronic subdural hematomas. So I think, on each individual case, work with your primary care physician and they can kind of walk you through that. But that might be a function of just blood pressure being high during these peaks during exercise.
I know it's hard to, obviously, you can't diagnose somebody over a question or whatever.
Sure.
So another question was, someone says that after a traumatic brain injury, when they have migraines, they have memory loss. Is that something you would suggest to them that they get checked out?
I think anyone that has abnormal neurological symptoms should be checked out, starting with their primary care doctor and then getting the appropriate referrals. Sometimes people have severe traumatic brain injuries or a history of series of concussions. There are permanent, neurological symptoms that can fluctuate or that can be always present. I think you see that with, in the NFL particularly, you have quarterbacks that, Andrew Luck's a really classic example of someone that retired kind of earlier than what other quarterbacks may have played because he was worried about the long-term sequelae of chronic repetitive head injuries. With this particular disease, as opposed to like repetitive traumatic brain injuries or severe traumatic brain injuries, these are usually more insidious, and to really the definition being that there wasn't a traumatic, inciting event usually. The exception being that case I talked about where there was clear trauma and there was a known subdural, and then that develops into a chronic or a subacute one that becomes chronic. That's an exception, but in general, we're talking about acute subdural hematomas in this grouping.
And our last question, Paul says, is there a treatment for cerebral amyloid angiopathy?
That's something generally, when people come in, when we set in our surgery, is when people come in and they have a hemorrhage, and that ends up being kind of the cause or the case behind it. And those hemorrhages in general are characterized by not needing surgery. They generally are self-limited or contained. But if they're big enough and they're causing symptoms, then we can evacuate them.
Okay, well, thank you so much, everyone, for joining us. We hope this gave you some insights into brain bleeds and aging. To make an appointment with Dr. Bowers, call 810-262-7030, or you can head to hurleymc.com.
Thanks for having me.
Have a great day, everyone.
Appreciate it.